So we're now going to turn to our first duo, and that's Paul McLaughlin and Clive Smith. And Paul is a clinical specialist physiotherapist in haemophilia at the Katharine Dormandy Haemophilia Centre and Thrombosis Unit at the Royal Free Hospital in London. He's also the chair of the Haemophilia Chartered Physiotherapists Association and vice chair of the European Association for Haemophilia and Allied Disorders. Paul is currently a NIHR-funded clinical doctoral fellow with research focusing on pain management interventions for people with haemophilia. And I'm not sure I need to introduce Clive, but Clive Smith is living with severe Haemophilia A and is chair of the Haemophilia Society. He's also a board member of the World Federation of Hemophilia. Clive is a barrister practicing criminal law, and they're both going to talk about the importance of a full multidisciplinary team in care for haemophilia and other bleeding disorders. So I think, Paul, are you going to start us off?
Clive is, I think.
Clive is, right. Okay, over to you, Clive. Thank you.
Thank you very much, Dan. Thank you for that introduction. Good afternoon, Paul. I think we should first start off by disclosing how we know each other. I'm your patient and you're my physio. And that's been the case for at least about 15 years now. And I suppose that in itself is a story in terms of haemophilia treatment, because we're going to look at this today, certainly from the aspect of physiotherapy and physical exercise and the way we've managed to have a successful relationship. But I suppose the other thing to mention is that part of the reason we've been able to do that is because we've known each other for a relatively long time now. And so that continuity of care has been really important in our relationship. So I think probably going back to probably maybe 10 years or so ago, I know that when I was coming to the Royal Free, that every time I came, I would come into the room and there'd always be my doctor, there'd be the nurse, there'd be the physio, there'd be a psychologist. Everybody was around and about, and I could always speak to one of them. Invariably, once I left the consultation room, I'd go and have my bloods, and that's usually where you and I would then have our own conversation, and we talk about sport and exercise. And I think things really came to a head with you and I in terms of when we were really having a lot of contact with each other, when I started to have real problems with my ankles. I'd always had trouble with them growing up as a child. They were my target joints, and I spent 3 weeks out of 4 really on crutches or in wheelchairs for a couple of years in my early years. But then it came to a time when obviously prophylaxis improved my care. And when 10 years ago, when you and I were really getting to know each other, then it was when I was really starting to get active and involved in sport, and I wanted to run. And you'll remember, Paul, it came to a time when I had some real issues with my ankles, and actually I think I had a month off work where I couldn't walk and I couldn't run. I couldn't walk at all, couldn't go to work. And so you and I had to then talk about how we were going to approach things differently. And we very much did that together. And I know I've said this more than once, Paul, and I'm more than happy to say it again, but the most important conversation you and I ever had was when you said to me, Clive, you said, whatever you're doing, tell me what you're doing and we can work with you and help you. So Paul, how did it work from your perspective in terms of how we work together?
I think that demonstrates, I think, as you say, the longevity of the relationship, which is quite typical of haemophilia clinicians as well. We tend to be around for a long time, but it's embedding the trust in the relationship, and also the acknowledgement that I may be a treater in haemophilia, but you are the person who lives with haemophilia. So the fact that you will come in to see us ad hoc in the centre, you're still living with your condition and all the things that comes with it for the rest of the time. And actually, the days of physios telling a patient what to do are hopefully long gone. And it's actually about working out what works best for the person in their own environment and their own beliefs and their own things that they want to do. And that is probably the exceptional piece of what physio is able to offer in haemophilia. Is that very in-depth. We're allowed the time to sit down and work things through with the patients that we're seeing. The physio obviously works within the team, and of course the multidisciplinary aspect of that is that often the physio is the linchpin to some degree between the patient's daily experience with musculoskeletal problems with haemophilia and back into the sort of medical nursing team around being able to facilitate conversations around activities, things that people want to do, and to make sure that we find the safest hematological way through, but also the most efficient and effective things that patients want to do. And I think the MDT acknowledges that everybody brings their own skills and knowledge base to that patient, and that at various points in a month, a year, a lifetime, we will all be involved at different points for different reasons. And for many young men, Clive's just about still in the young men category. They are living with joint disease of various severities. And so we need to be able to work out a way of maintaining physical wellness and ability to allow people to do what they want to do. And I think that Clive's story is a good example of that. And I think, as you mentioned, Diana, the peer review highlighted that 50 to 60% of services in the UK for haemophilia have insufficient physio. And that figure is astonishing, really. And I think the case is even worse for things like psychology services, where there's even less. It's not even access, it's actually availability. There just isn't a person that they could even be referred to locally. And I think it's beginning to see haemophilia within the medical paradigm of treatment, but actually treatment with clotting factor or treatment is only one part of the story of living with haemophilia, because it's highly complex, and there's no getting away from the fact that it's a highly complex condition to treat and a highly complex condition to live with. Would you say, Clive? Complex.
Yeah, but it is, as you'll appreciate, Paul. I mean, in terms of that journey, in terms of where we got to, as you said, some people know my story, some people don't. But I think it's important to say that in terms of where we got to a stage where I wasn't walking on my ankle for a month to me completing an Ironman triathlon and running marathons. This wasn't just about getting me back on my feet and getting me back to work and doing those sorts of things. This was about breaking boundaries and really doing things that no one else had done before. Lots of people may have seen at the weekend a young man with Down syndrome who completed an Ironman, the first person. I was the first person with severe Haemophilia A to do it back in 2014. And that's where we got to. But as a result of our relationship, it was a case of, what do I want to do and how can you facilitate that? Hence why that conversation was so important. But as you say, Paul, I know you certainly you were on the quality review teams, as was I as a patient representative. I was in Manchester, for example. There are over 1,000 people with bleeding disorders registered in Manchester. They've got no psychological support whatsoever for over 1,000 patients. That was the case in November last year. I don't know whether it's changed now, but that's simply unacceptable that there's nobody there whatsoever when there's such a large population of people with bleeding disorders who are not just being underserved, but they're not being served at all. And I wonder, Paul, if I'd lived somewhere else, even in the UK, we talk about the disparity of care across the world in haemophilia, but if I've lived somewhere else in the UK, would we have achieved what we did together? Because I doubt it.
Probably not. And that's not disparaging to any, you may have found another physio as well. And so it's not so much about there's the difference between having access to physiotherapy and having an ongoing relationship with a person who is a physio who understands you and your condition. Those are two very sort of different setups, and it's easy to tick the box to say you have access to a physio, which is a referral to a different department where you see a different physio for each thing that you have a problem with. And again, that's frankly not good enough, because this is a long-term condition, that has other chronic conditions associated with it. And I think that the skill set of the physio within the wider team pulls that together. And the aspects of quality of life and being able to live well, the report draws the figure that when they looked at the EQ5D, which is a quality of life measurement tool where you can compare disease groups with each other because of the way it's calculated. The haemophilia patients in the UK is 0.59, where the national average is 0.85, where 1 is the best quality of life ever. Compared to other patients across Europe, Germany's haemophilia patients is 0.9. Again, the UK is 0.59. Clearly something's not working, something's not right. There's something that we are not providing as a healthcare service to enable people to feel that they have good quality of life. And that is a subjective view of your own life, to feel that you are able to do the things you want to do. And we have to do, it has to be better. There has to be equity of care, and people have to get access to that care because it has to be provided. And I think it's sometimes batted into the long grass where you've lived this long and you've got this far with your haemophilia that it's okay. Maybe you just get along with what you've got. And I think, that notion of the disability paradox gets thrown around. And I think, somebody like Clive can describe that a little bit better. As I say, I can empathize with, but I do not live with this as a condition. Do you think the disability paradox is a thing, Clive? Does it exist?
Yeah, absolutely. And I think especially for people probably around my age, as it were, because I think I've known haemophilia treatment to be different to how it was 20, 30 years ago. And we talk about the disability paradox, the fact that if you ask somebody with a disability, haemophilia, for example, how good is their life? And they might say, well, mine's a 9 out of 10. Yet if you were to objectively score it, actually, they might score 7 out of 10. But because it's significantly better than how it was, they'll have a different view. And certainly I may be guilty of that, in the sense that I talked about the fact that I spent a lot of time in crutches and in a wheelchair when I was sort of 7, 8 or 9. So if you were to ask me how good my life is, well, compared to that, it's a 9, 9.5. But if you look at it objectively, how good is my life compared to somebody without haemophilia? Well, is it as good as it could be? Well, my life probably is, but that's because I'm at the Royal Free and I have a comprehensive care team looking after me. And I think the one thing we need to be mindful of is we talk a lot about annual bleed rates, and I think there's a big focus on that, and rightly so to an extent. But just because somebody stops bleeding, somebody with a bleeding disorder, it doesn't mean all of a sudden they're cured of everything that went before. And I read an article only this week, and it talked about us being careful that technology isn't the messiah, in the sense that just because new technology comes along, that doesn't make everything better all of a sudden. So, for example, but with my ankles, I've got arthritis in them, and at some point they're going to get worse and I'm going to have trouble with them. And there are all the other things that, of course, people with bleeding disorders have had to encounter over the years. So it's not like a new technology isn't a wand whereby we suddenly magic all the problems away. As we know, it's a lifelong condition. We know that as a society, you know that as a clinician, Paul, that people have touch points in their life as well, in terms of when they're born, in terms of going to school, in teenage years, leaving home, all those sorts of things. And all those things still need looking after. And of course, the big issue at the moment, or one of the big issues, is of course aging with haemophilia, because for the first time we do have an aging population, which is a good thing, but we need to look at ways of dealing with those. And that's something that this report obviously looks at, which is incredibly important.
I think that the life narrative is really important, and the fact that the narrative changes and your own interpretation of your narrative changes with each touch point that you have. So good and bad experiences will continue to sort of make you develop behaviors that may be positive or negative towards your haemophilia and your activities that you want to do. And I think it is a problem that there aren't enough people in these roles. It is underfunded, it is under-recognized, and that's not for want of expertise. In the UK, we have some of the best physios, nurses, psychologists, doctors working in haemophilia. Certainly with physio and nursing, we are represented at a national, European and world level on boards. Yet 60% of their centres in the UK don't have access to a physio. So the group of physios that are here in the UK are dynamic, we're research driven, we're clinically driven, and we have it there to give. We would just like more people to be able to sort of share this knowledge and train up, essentially. And I think that's the crux of it, that actually it needs to be recognised, and it needs to, people need to be there to develop that expertise with and for. And we need to be thinking that the lifelong nature of haemophilia and the developments in treatments, in that we're celebrating medically, we have people who are aging with haemophilia, but at what cost? Physically, functionally, being able to live your life. And I think, as Clive said, we have to get away from just bleeding as the endpoint. So resolution of bleeding through a treatment is one thing, but actually living better and having the people in a comprehensive care setting to help you do that is vitally important. And I think it's pushing to be more, pushing that expectation. Would you say, Clive?
Yeah, very much so. Certainly from the patient point of view, it's about pushing expectations about what's actually possible, that it's possible to stop having bleeds and to have a full life. And I think somebody being treated in Newcastle or Manchester or Leeds should have exactly the same opportunity as someone living in London, Southampton and Bristol. And I think at the moment, because there are so many options with treatment as well, that people need to, I don't think it's ever been a more important time for patients to be well educated and informed about treatments that are available and their options. Because when you go to appointments, and you'll appreciate this, Paul, you don't always have the time to talk about everything, I'm sure. And I think one of the benefits of me being a well-informed patient is when I go to a consultation, all that information that you or Professor Chowdhury or someone might be imparting to me, I've got that already. So we can already start having a conversation about it, a two-way, genuine conversation about treatment. And as I say, I agree entirely that absolutely it's for patients to push expectations, to push the quality of what is provided for them, and to ensure there is equity of care. And for some people, they only become aware of that, for example, when they go to university and they move to a different centre and they realise that something's done differently somewhere else. And it's only when they may be in their late teens, early 20s that their eyes are suddenly open to a different way of doing things. And that needs to be happening a lot earlier in the patient journey, I think.
Yeah, that's us, Diana.
Okay, that's great. Thank you. That was really interesting, and that format worked really well, didn't it? Having that conversation.